Thanks for having me. You know, at lunch I was talking to Diane Lund, and those who are important to know, Diane runs a healthcare policy newsletter. And I said to her, you know, when she first wrote the article about me becoming CMO of the health plan, I said it was so nice I actually could send it to my mother, who didn't really understand what I was going to be doing. So now I have this introduction, and I can tell my mother, he's not that bad. So I was asked to come up with a catchy title, you know, about what insurance companies actually do. Can't live with them, can't live without them. Actually, that's not really true. People probably could live without them. A lot of places live without them. But at the same time, we also can recognize that there's a distinction between single payer and no insurance companies, because there are many single payer systems that have insurance companies. And what I'm going to try to do today is, after a little introduction about some of the challenges in the healthcare system and some of the impact of the Affordable Care Act, and I'll go through some of it kind of quickly because some of it we've already covered, to actually kind of describe a little bit about what we bring as a payer and why that's not going to be so easily replaced by just a single payer or government regulation or the ACOs. So we actually think we do serve a useful purpose. So I think as already talked about today, challenges in the U.S. healthcare system, cost, access, variation, and quality, a lot of fragmentation, lots of issues. This slide, you know, Paul showed, although I think I have one that's maybe a little more updated that shows that GDP growth is kind of stabilizing. But, you know, the gap is still there. We spend a lot more of our GDP on healthcare, and that crowds out other things that we also need, as Meredith Rosenthal pointed out, like education and transportation and other services that are actually things that are societal goods. But access is improving for people as a result of the Affordable Care Act, and there's a bit of a success here. So this shows the percentage of uninsured folks, and it does a little bit of an age band. And you know, so the percentage of uninsured has dropped, you know, in this slide to 13%. It's actually a little lower than that now. And the thing I just kind of wanted to point out here is that the uninsured rate in the near elderly is even lower. And one of the challenges around the exchanges and the cost has to be the risk of the population. So Paul Cleary showed that in Oregon we have rising rates that are much higher than they are in the rest of the country because our rates probably were too low to start. But part of the key to getting this to be affordable for everybody is we have to get these young healthies in the pool. And everybody's got to be in the pool. So hopefully with the incentives ratcheting up as people become more aware of that, because the penalty if you don't join in 16 is 2.5% of income or $695, whatever's greater, that will get people in the pool. One thing that you also, almost 60% of the people that are enrolled in Marketplace is basically the exchange. If you have to get a subsidy, that's called the Marketplace. But almost 60% in the Marketplace or Medicaid were previously uninsured. So there are many aspects of the Affordable Care Act that are working. Medicaid is making a difference. So this slide looks at adults 19 to 64. The blue bar is private coverage, the gold bar is Medicaid, and then, you know, the red one is if they were uninsured. And it asks questions like, it's a survey to patients. Do they have a regular source of care? Medicaid is just as good as private insurance. They have a regular source of care. Rating the quality of the care, they're actually feeling pretty good about the quality of the care. And yes, they're having some trouble with access, and it's a little greater in Medicaid, but it's not like it's off the charts. So, you know, do carriers have a role? And so my health care services researchers might be able to answer this question. So I'm going to propose a hypothesis, and then I look to you, you know, because I only have limited data. I tried to find it. I couldn't find the data. So we know that states are moving to managed care organizations to administer their Medicaid plans because they just don't feel like they can do it. You know, and so almost half of the Medicaid beneficiaries in the country now receive their care from a managed care organization, and there's been rapid expansion of MCOs. I did find a reference that showed that PCP appointment availability in Michigan actually increased after Medicaid expansion. So access didn't get worse when we had this flood of patients in Michigan. It actually got better, and they had a 9% increase in Medicaid MCO enrollment in Michigan. And my hypothesis is that may be facilitated by managed care organizations. And why? Because insurance companies have networks. And so, you know, if you don't have a network, you don't have anybody who has necessarily has a responsibility to take care of you. And our responsibility in putting together that network is to make sure that it's adequate for the enrollees, and actually to advocate for them when we know that patients have a need. So we have customer service people, you know, we have case managers, and we have to find them access. And because we have a network, we can do that more effectively than if people don't. And so be interesting to know if states that have more managed care enrollment have better access for their Medicaid enrollees than those that don't. These slides I'm going to kind of just go through. Yes, we spend a lot more for pharmaceuticals because we don't negotiate drug price. Hospital spending is greater than it is in other countries. Price is a big issue in our increase in cost. I would make the case that I think that maybe public payers are contributing to the high cost of commercial insurance because they pay so much less, and that does put pressure on things. And the issue of what's the right price, I think, is a matter of debate that maybe we can talk about in the panel. People talked about physician incomes being much less in other countries. They also have subsidized medical education, and we have more income inequity in this country, so there's a political component to that as well that we just can't deny because there's a market, and so they're all factors. And Americans aren't necessarily seeing physicians any more frequently. In fact, they're seeing them a little less frequently. You have 4 visits per year. This is 2011 data, and they see doctors more in other countries. Whether that's effective care or not, I think, is also open for debate. And as Dr. Rosenthal pointed out, we have to stop thinking of access for care as the traditional patient in front of me, that we have a whole new world of technology like email, telephone, video visit, asynchronous platforms, et cetera. And Providence Health Plan, I think we have a record of trying to incentivize some of that because we pay for phone calls, and we pay for e-visits, and we pay for video visits, and we're hoping to get on board on an asynchronous care platform. And so, and Medicare will be behind us. Government payers will be behind us, so health plans actually can be more innovative. This is a paper from Health Affairs, and it looks at utilization, and it compares Medicare Advantage to fee-for-service Medicare. And the green, anything that's 1, so that's this line right here, is greater utilization than in Medicare, and less than that is less utilization. So outpatient services for established health plans, they use outpatient services a little more than fee-for-service Medicare, but you can see these very significant reductions in emergency room use and inpatient services as compared to fee-for-service Medicare. So you can ask the question, is that skimping, or is it that it's more efficient and better? And I think that the point of this paper is that it appears to be more efficient and better use of resources, because they also compared something like coronary bypass grafting versus a stent, a percutaneous intervention for a stent. And because, for a bypass, you actually have to crack somebody's chest and open it up and do some stuff. It's not like people are signing up and say, gee, I think I'll do that, when it might be marginal. On the other hand, a stent, well, that's a pretty minor procedure. And we know that there's been, and I'm going to show later on some things that we've done in the health plan, where there's been a lot of variation around that, and there has been some low-value care. In the appropriate circumstance, it's high-value care. But Medicare Advantage plans actually do more bypasses, quite a bit more than fee-for-service Medicare, but fewer stents. So it's raising the point that there actually is some evidence that more effective care is actually provided by Medicare Advantage, and it's not all that bad. A comment was made earlier about the surplus that Medicare Advantage plans, get, and some of that's going to be eroding. I'll say right here and right now, give me the national average, adjusted for the severity of illness of our patient population, adjusted for the cost of living, and other factors, and I'll take it. I'll take it right now, because then I don't have to think about Louisiana and South Florida and every place else. And providers do a more effective job, adjusted for all the risk. I mean, North Dakota and Manhattan is not the same. The fees shouldn't be the same. I'll take national average right now. You have it on record. All right, what about satisfaction between private insurers and Medicare and Medicaid? Several years back, Steffi Woodhandler and Health Affairs published a paper that said that health insurance companies add $68,000 a burden to a private practitioner. I practiced for several years. I had Medicare and Medicaid and private insurance. I am, fully disclosed. Don't put this one on the paper, Diane. I'm a committed Democrat, but they keep trying to turn me into a Republican, but they haven't succeeded yet, because regulation is a killer. And whereas Medicare doesn't show up on their costs, you can ask doctors about the forms they fill out and many of the things that are imposed by Medicare. Medicare makes the requirements for a chart note for billable services that add a lot of burden that don't show up as administrative costs, but they own a big piece of it. And I got a lot of nods from my healthcare researcher folks. And so if you look at physician satisfaction about reimbursement, there's a good chunk of people that are just unhappy in general, but they're less unhappy about private payers. And then if you're asked about the ease of administration, so all the things that we do that irritate people, prior authorization and coverage policy determinations, et cetera, they're still less unhappy with us. So I thought this was kind of interesting. It doesn't mean that we can't do better and have to figure out ways of relieving administrative burden, because that's a waste, but at least physicians seem to be more unhappy with some of government regulation than they are with the private payers. So now a little bit about Providence health plans. We have a long history here, so it's actually almost 30 years. We have 500,000 member lives, mostly in Oregon. That's a mix of patients who are fully insured, where we bear the risk. We manage a couple of large self-funded plans, the state of Oregon and Providence Health System employees. We are in Medicare, we're in Medicaid, over $1.5 billion of top-line revenue. One of the things I think is different is that we're a provider-sponsored plan, so our focus is really deep engagement with our provider community. It's not just about paying claims. We have a lot of regional clients. We also have about 78% of the Oregon State public employees, and I think that controlling their healthcare costs has allowed the state to fund lots of other projects. It really speaks to some of the benefit of trying to have some control over healthcare costs, and as I mentioned, other self-insured clients. So this slide is basically just to kind of show you the trend of what we pay on a commercial plan across the state of Oregon and trending it over time. And you can see, and this is actually what the plan pays. And so I would make a comment that one of the challenges I think that we're going to start having, that we have already, and that is a big issue in the exchange population, is the burden of cost shift to people rather than, and that's the way premiums have been kind of stabilized, is to shift more cost to patients. And we're probably at the end of that road before insurance becomes less useful for people. And that's a challenge on the exchange population, because many of those patients also have more limited means. So I won't deny that the cost share is a burden to people, and without the cost share, the premium will price people out of the market. So we still have a cost issue, but we are in this together. So you can see that there's actually been a fair amount of stabilization on the hospital side on what gets paid, and a little bit of a stabilization on the specialist side, but that's where most of the money goes. Prescription trends are going up, and actually because of just the timing of this slide, and as I mentioned, this is claims paid versus allowed, we're seeing double-digit increases in prescription costs. We're a plan that does make investment in primary care, and you'll see that our administrative costs have been stable for many years. There's not a lot of increase in the absolute cost of administrative costs. You see this bump in 15, which does have to do with some of the implementation of the Affordable Care Act and the taxes that we have to pay in the Affordable Care Act. But that isn't necessarily so bad, because that's where some of the funding mechanism comes in to give people insurance. So, it's just what it is. So, but if people were wondering about that increased cost and administrative costs, that's the bigger factor. So, and I really wanted to emphasize the stability. So it's not like we're kind of trying to squander the people's money here. We do have a story in Medicare, and one of the points I kind of want to make is that Medicare really is kind of like it's single payer with private insurance companies administering it. And one of the things that we can bring is be a little bit more flexible and creative about how we allocate resources. So, and then if we have effective care, we can pass that benefit on to providers who are providing effective care, and we can keep costs more stable for patients, for members. So this slide looks at the effective reimbursement to our, the blue bar is primary care, the green is specialists, the purple is hospitals, over time, as if they were providing those same services on a fee-for-service basis. And what you can see is that we have a history of paying primary care doctors almost double, and specialists getting about a 13% premium, and on the hospitals in the past have done a little better than Medicare, but now it's about even. And then this is going to be a tough year. We've had a lot of extra costs this year, and so but we think we have some that we'll be able to right that ship and get things back into a little bit more norm. But the point I want to make here is that everybody talks about primary care and the inadequate resources. And plan can be more flexible and creative to do something about that so that we can allocate the resources. And I think most of the primary care doctors in the community, we have a long-standing partnership with the Portland IPA, will attest to the fact that we treat them fairly and we're trying to work together with them, and it does keep their practices, I think, afloat. So the creativity we bring on payment innovation does have benefits. And the next slide is just looking at the member premium. So again, the emphasis here is on some stability over time. The top bar here, we have two different plans. One of them is less expensive than the other, and that level of expense has to do with either benefits and or choice. And you can see it's gone up a little bit here in the last year, but there's a lot of stability of what patients have been paying. And then you can start to see there's some change here in Part D with this, which means that it includes the prescriptions. And that's going to be something that's a little bit more of a challenge unless we get a handle on pharmaceutical costs. But if you look back historically, again, these are not really extreme increases in premium, so there's been a pretty good story about providing value to people. So what do we do? So this is kind of heard of triple aim. We want to improve population health, want to keep things affordable, want to give people the best care experience. These are the functions of my departments, which are in the quality and medical management and pharmacy arena. We also have customer service and claims processing, and I think customer service is important for the reasons Dr. Schlesinger pointed out. There's a number on the card. We get people our cards, and it's our job to actually help them get the care that they need. And we have case and disease management programs, which are kind of centralized and standardized. I think physicians can do some of this internally. But the ability to scale, make it efficient, standardize it, get the same level of quality is a little harder the more fragmented it is. So I think plans do have a role, and even if some of this gets embedded into the practices over time, there's also a role for training, standardization, and monitoring to see that the outcomes are what they need to be. Wellness programs, educating patients, quality performance and bonuses, administering those, pharmacy management, managing that the care that are in hospitals is appropriate and that we have good coordinated discharge plans, prior authorization, which I know people don't like, but when we say no, there's a reason, and it does allow for the implementation of evidence-based medicine in a reliable way. We're responsible for the quality of our network, and we help providers understand where there are gaps in care. This slide basically shows that a minority of the patients really consume a lot of resources. 1% of the people, 30% of the cost, 70% of the resources of the people, 10% of the cost, and a lot of people don't cost anything. So what health plans can do is we can use predictive modeling to identify who these people are. And if you actually look at issues around the case management that are embedded in practices versus embedded in plans, you can find some interesting things. So it's true the engagement is better when the case manager is embedded in the practice. It's also true they identify a lot of people who are not going to benefit from case management because they can't identify who are the people who really need it. So there was a paper in the American Journal of Managed Care. Can't speak for how well peer-reviewed that is, but assuming that it's true, it is. I got the thumbs up. And it's a paper in that said that primary care practices identified 38% of their people as being eligible for case management with a 50% engagement. Plans identified something in the low teens with less engagement. And the point here is that we need to work together. We would do a better job as a plan. We can help them identify the right people. The practices can do a job in making sure they get them people engaged. So I think the level of partnership, but the plans have a role. It won't be done with ACOs alone. And how do we do this? We identify and stratify people. We use multiple data sources from claims and pharmacy, looking at patients who have high cost or specific diseases, who have gaps in care, high hospitalization readmission rates, emergency room use, predictive modeling, health assessments and questionnaires, biometric data. So we really do have the tools to identify people who are going to need more intensive services. And we have embedded case management using standardized tools like the patient activation measure to identify where are they at in their journey to being able to self-manage their conditions, from being at a very low level and not knowing much about their disease to being fully activated. And we track people's levels of engagement and the outcomes on people that we have in our case and disease management programs. Some of this can be embedded into practices, I believe, but they will need the infrastructure support and support for standardization and model and monitoring of effectiveness. This is our success story on using our disease management programs. This is data from the Disease Management Purchasing Consortium, who classifies Providence Health Plan as one of the top 2 plans in the country. Here's our record from when we embedded these programs into our services, and these are event rates for diabetes, coronary disease, emphysema, heart failure, and asthma. These are their national average rates. These are our rates, and you can see they've been stable over time, and we've continued to be able to widen the gap. So, whereas there's evidence that that case management programs and health plans that are phone-based are not that effective, our experience is different, and I think our experience is different because we're a provider-sponsored plan deeply engaged with our providers. I think that's our secret sauce. So some interesting things around data that Cheyenne alluded to. I think that if you give people information and you share that with them in a way that is committed to scientific inquiry and is respectful, you get results. And you can have money attached to that, or you don't necessarily have to, because we do pay bonuses, but some of our success stories have not had money attached to them. We have a long history of sharing quality data with providers. So this is kind of a snapshot of a group practice quality profile. We've been doing this for over 10 years. Each one of these are parameters that range from looking at care for what we call ambulatory sensitive conditions like respiratory conditions or heart failure, to certain access issues like emergency room use, to certain preventive measures for chronic disease like diabetes and lipids or mammography. And green means you're in the top quintile, and white means you're in the middle, and yellow means you're between the 20th and 40th percentile, and red means you got some work to do. And you can see that there's variation there. We have shared with people patient-level data, and this is something that I think Medicare is not able to do yet, and they will have some challenges doing that over time. So, our clinic leaders can look at their snapshot. Any clinician can look at this. They can drill down, and if they drill any one of these things, they'll get a list like this and says which patients met the measure and which ones didn't. And we actually accept feedback from the physicians to say, they either got it or, the patient actually met a clinical indication to get the service. An example being, we measure inappropriate antibiotic use. If the clinician should show us documentation that says the patient would have met the criteria for the Infectious Disease Society of America's criteria for getting an antibiotic because they actually had sinusitis with the clinical parameters that warrant an antibiotic, we take them out of the measure, but they have to show us, and that means that engaged physicians tend to get better scores, and it drives clinical performance. And here are our results. This is when we started in 2005. This middle line is where we were in 2010, and we've continued to have performance improvement over the last 3 years. And I'd point out that this yellow line, we had a lot of geographic expansion between 2010 and 2013 because that's when we started to administer the state of Oregon employee contract. And so despite that, people who have not had those years of quality monitoring, we are still getting improvement, and we still got some work to do on the tail, but the tail has not grown with a bunch of new providers coming in. We've shifted some of that over. One of the things that plans can also do is we can be a little more nimble and faster on quality improvement. So I call it if you follow hockey, you remember Wayne Gretzky, you want to skate to where the puck's going to be. So this is a slide that looks at our statin usage for patients who have established coronary disease and diabetes. So a couple years ago, there was a new lipid guideline put out that said you don't need to measure LDL levels anymore. They may change that now, I don't know, because there's some new evidence. But they really, it was quite clear that statin usage was going to be the thing that we really wanted to measure. That we wanted to know that patients who had clear indications were on a statin and they were on it at the right dose. So we started measuring this a couple of years earlier than NCQA is just putting out what their test measure is going to be. We started doing this 2 years ago. So plans could be more nimble because we can skate to where where we think the puck's going to be. And we got work to do here. This is kind of a shocker. This is basically looking at the proportion of patients who are getting a statin, who filled a prescription for a statin within the previous 4 months. So clinicians think that they're taking it because it's on the med list. They must be taking it. It's on the med list. I see it right here. And they come in and say, oh, they're on a statin. But if they're not filling it in the last 4 months, they're not really taking it. And the way adherence measures go is if you didn't fill it in the last year, it doesn't come up on the denominator. So adherence measures are also kind of flawed. So you need to marry the data together, and you need to weave this clinical story. And there's a lot of opportunity, and we're starting to get some. This is our baseline data, and first year we had some movement up, and I'm hoping for more movement up this year. And this is on our quality bonus where we pay our doctors, and we have a good partnership with the Portland IPA, and we're pushing this, and we hope to be ahead of the pack. And I think some of the folks in the room know that for 14 and 15 we've been a 5-star plan, and that's really hard to do. And we intend to keep pushing along so that we're really at the top. We do look at practice variation. This is looking at cardiac procedure rates in 6 different regions in the state of Oregon using the state of employee data. There's a lot of talk about ACOs, but ACOs will know their own performance. They could probably benchmark it to national benchmarks, but they can't do the level of variation analysis we can do as a payer. So these are all different regions in the state of Oregon, and anybody can see that there's something going on here in this blue community, dark blue. I don't want to disparage the light blues, but there's something going on here, and this was our baseline data in 2011, and because we're a provider-sponsored plan, I didn't think I wanted to do that. Because we're a provider-sponsored plan, we can kind of, talk to the cardiologist and say, okay, what kind of drives this? I mean, the genesis of this was a paper actually published in the Journal of the American Medical Association that showed variation about appropriate use rates for stents. So they gave me the idea of getting the National Cardiovascular Data Registry data, because every hospital in the state that does interventions participates in it. So we went to our hospitals and said, share this with us. And then what we did is we did some comparison, and we partnered with the American College of Cardiology at the state level and said, let's get all the cardiologists in the room. Brought in the past president, did this in a blinded way to try to not attack anybody. That's I think some of the problem with wanting to have a lot of report cards is you don't necessarily get the camaraderie that you need to get improvement, and you may not be able to account for some of the legitimate reasons why there is variation. But this institution E is in that community that had the big blue spike, and what you can see is that they had fewer patients who had heart attacks or unstable angina getting stents, and more patients who were stable. And there's evidence that medical therapy is as effective at preventing heart attacks or mortality in patients who have stable angina. And so we had an opportunity to engage. This is just looking at the appropriate use criteria. That same community had the fewest proportion of patients that were appropriate, and more in the uncertain category. And so we shared this information, and these are the results. This is when we shared it. We shared it here, and you can see this good, 30-35% drop in the use rate. It's been sustained. I mean, although this slide shows 13, I could show it, could update. I stopped updating it every quarter because it was the same. And this is, I thought I had a slide here that actually showed the variation has dropped. So that big blue bar is not quite as disparate as it was. There are reasons why different communities may have different differences. It wasn't age and demographics, and it doesn't mean that it's always going to be the same. So, there are going to be some communities that might have, I think a state worker in a prison is not going to be the same as a university professor. That might be my bias. I may be incorrect about that, but I think that my hunch is pretty good. And so the idea is not to be pejorative. This is looking at stress test data, and it basically looked at patients who got any imaging with a stress test. Dark blue bar is a nuclear scan. This is a stress with an echo. But these are patients who got both a stress echo, a nuclear scan and an echo within 5 days of each other, which has some clinical indication, but this variation cannot be explained by anything clinical. So what do? We met with those practices. We agreed to do some retrospective review. We had an independent cardiology review the results. The review revealed that 90% of the cases met appropriateness because what happened is these numbers were cut in half. So sharing information, doing it in a way that looks at the literature, doing it in a respectful way, and payers are in a unique position to do that. We get a unique position to do that in ways that I think that single payer can't or a single ACO can't. So I think we can inform physicians on practice and opportunities to improve value. We can be transparent. Payment reform has a role, and we can maybe cover some of that, may increase quality and appropriateness, but it's not the whole story, because the literature on payment reform is not so great. It takes a combination of resources and engagement. And I think that we have to do this because there's new treatments coming up on the horizon that are legitimate, that have to be paid for, like hepatitis C or new cancer drugs. And we can't do it and control costs unless we can get the waste out. So that's my 30 minutes. I hope I didn't go too long.